Neuro Part 2. Here's your objectives. First thing we are going to talk about is the different strokes along with mini strokes. There is your patho if you need a little brush up on it. There are slides for parts of the brain and the cranial nerves. You do not need to know those for testing purposes, but they are there if you would like to take a look at them. So there are two different types of strokes. You have the ischemic, which is the blockage. And that's the one where we give the TPA, the clot buster. And then you have the hemorrhagic, which is the brain bleed. That also can be subarachnoid hemorrhage. And then there's the intracerebral hemorrhage. Regardless, both of them are brain bleeds. Then we have the translucent ischemic attack, or the TIA. So for an ischemic attack, we are giving the patient the clot busting medication. And when we are giving that medication, there are some things that we'll talk about to look for. When it comes to the hemorrhagic strokes, we're very often going after treating the signs and symptoms. And for a TIA, this is the mini stroke. This is the one where the patient will have full signs and symptoms of a stroke, but it resolves in 15 to 20 minutes. Make note that patient's probably going to be on forever aspirin just to prevent any issues moving forward. So different signs and symptoms that we look for. So when we are watching somebody with a CVA, especially when they are getting the clot buster, watch those vital signs. Okay, their respiration rate's going to go up, their blood pressure is going to go up, and that Glasgow Coma Scale is going to start slowly coming down. So it's imperative that we are watching for that. The main diagnostic test when a patient does have signs and symptoms of a stroke is a CT scan, a head CT scan to be specific, sorry, head CT scan. Very often we are going to be doing the National Institute of Health Stroke Scale and a Glasgow Coma Scale, so we have a baseline. So the lower the NIH scale, the better the patient. So if they're over 21 points, it's severe. 16 to 20, it's moderate to severe. 5 to 15, moderate. 1 to 4, minor stroke. Possibly 1 to 4 for a minor stroke could also be a TIA. And again, if that resolves, we know it's a TIA and it's probably not going to show up on a CT scan. And a 0, no stroke symptoms, we are clear. Then you have the GCS. And again, the lower the number, the more severe the injury. Treatments. I already mentioned it, but when a patient has a hemorrhagic stroke, very often we're going to go with that TPA, the Applies. This is the clot busting medication. We are going to be watching for bleeding, so blood pressure going down, heart rate and respiration rate going up, and Glasgow Coma Scale going down. Those are key signs that there's internal bleeding caused from the TPA, and we need to stop the TPA from infusing. Okay. When it comes to the hemorrhagic stroke, we're very much doing symptom management, possibly surgery to do burr holes, or IR if there's any type of aneurysm that can be fixed. What we do with the stroke patients, we're watching for intracranial pressure increase. If we have an increase in intracranial pressure, very, very typically, the first intervention for the nurse is to sit the patient up, sit the head of the bed up. We're going to be watching those blood pressure trending, and we're going to be watching for ongoing treatments. Constantly reassessing for stroke patients. It's a constant reassessment, especially when we're doing TPA. Then we're going to go over to traumatic brain injury, better known as TBI. So, patho of it, there was a skull injury. It can be open, it can be closed. Closed, the skull is intact. Very often, this is also known as a concussion. When the skull is not intact or it's open, there could be a basilar, which we'll talk about, a depressed, a linear. Those are different aspects of assessments that will be done. We can do a simple x-ray to look if the skull is intact, if it is open, if it is cracked. The type of head injuries, you have everything from moderate to severe. When the differences matter, if they had a loss of consciousness, you will hear this in the ER. Did the patient have a loss of consciousness? Does anybody know if they lost consciousness? How long did they lose consciousness? Those are all aspects that is going to tell us or give us an idea of if this is severe or how severe it is. What is their GSF? How high is it? How low is it? That's going to be done in assessment. And then again, we're going to do a head CT for evidence of any type of brain injury. The different types of hemorrhages, we have an epidermal hematoma, a subdermal hematoma, and intercellular hematoma. That is the most fatal. When it comes to a subarachnoid hematoma, very, very often you will see this patient on a calcium channel blocker drip. And I'm going to spell the medication for you. It is NIMODIPINE. Nimapine, okay? That is a calcium channel blocker and is very typically given as a ongoing medication to help treatment because it is the most fatal. Signs and symptoms, all right. So when we have somebody that possibly has some kind of skull issue, okay, we're going to be watching for ICP changes. If the internal cranial pressure goes up, we sit the head of the bed up. Okay, that's the first thing we can do. CSF leak, cerebral spinal fluid leak. If your patient had a brain trauma, a TBI, and all of a sudden they have fluid coming out of their nares, grab the glucometer, see if it comes back for glucose. Normal sinus fluid has no glucose in it, but cerebral spinal fluid does have glucose in it. So if that fluid comes back positive for glucose, we know there's been a crack and we know that there is spinal fluid leaking, which is dangerous. The battle sign. Battle sign is bruising or ecchymosis around the mastoid process. It is a very typical sign after there's been a brain injury. It will heal over time. Then we have something called raccoon eyes. Raccoon eyes is where there has been a fracture around the orbital areas. There should be absolutely no pressure anywhere on the facial skull at all when we have raccoon eyes. So if you have a physician that wants to put like an NG down, absolutely not. You would question that. If they want to put like a breathing apparatus through the nose, you know, when someone's like losing consciousness, we have one of those airway openers that we can insert into the nose. That's going to be a hard no for this patient because we could actually cause more damage. We're also going to be watching for increased saliva production. If the patient is coming in out of consciousness, We do want to be suctioning their mouth to prevent aspiration. That's going to be a big one when it comes to these bleeding hemorrhages. And again, we're going to be watching those vital signs. It's very typical. You can see the blood pressure go up and the heart rate and the respiration rate drop down. This is a sign of increasing issue for the ICP. So some assessments we can do. If your patient's unconscious, actually one of the pain aspects that we can use to measure pain is we use the nail bed pressure. So press down pretty hard on their nail bed with your nail bed and see if the patient reacts. Posturing. Posturing is a very eluded neuro issue. Means the patient's not doing well and they're not doing well fast. This is the most concerning aspect when we have, especially when they have acute posturing, we're losing the patient and we need to call for help. We need to probably go in surgically or redo a CT scan. Something has changed if posturing happens rapidly. Again, with the increase in cranial pressure, typically the patient, the head of the bed is always at 30 degrees. So it's typically one pillow, maybe two, depending on how flat they are. So let's talk about some treatments here, okay? So one of the big drug treatments that are used is mannitol. Mannitol is the neurodiuretic of choice when we have a TBI. You should see the patient starting to urinate more. That is the first sign that the mannitol is working. Be very vigilant though. Watch your electrolytes, especially your sodium, because salt's going to follow water. And we have to make sure that we are giving the patient salt before it's needed. You also should be watching all the electrolytes in general. You guys, if you have if you are trending, which you should be in Epic, you can just click it to trend. If you see any of the electrolytes starting to drop, we should be replacing it before it's abnormal. So if the MEG is dropping, it was 2, now it's 1.8, now it's 1.7, we should be giving MEG. It's trending, okay? Call the doc, get the orders, standard orders in if they are not already ordered. If the patient is having any type of seizures, we could give sedatives. The most common sedative you see with traumatic brain injury and seizures is lorazepam. Again, fluid and electrolyte disturbances, we could have an endocrine issue. Watch for fluid volume overload, watch for fluid volume deficit, watch for the sodium level to start going down, the potassium level to go down, and start replacing before it's abnormal. If you see it trending going down, replace it before it's a problem. Complications we see. Seizure activity. This is a very common complication. That's where the lorazepam comes into play. I've had patients with severe TBIs in the ICU that they're on actually a lorazepam drip. Just enough to keep the seizures activity and keep them comfortable. It's not enough to put them into a medical induced coma. Hypotension, we are absolutely going to be watching the blood pressure. We're going to give this patient a lot of IV fluids, but if they start to go hypotensive, we know there is a blood flow problem. Hypoxia, if the patient is not breathing well, this could be an depiction of increased ICP. They may need to be intubated. Okay, there could be edema on the brain, there could be edema building up. We need to protect their airway. Nursing care, PT, OT, all that fun stuff. Have the patient safety. Again, we just talked about ventilating the patient, possibly a trach if it's long term. G-tube or TPN treatment. ADLs, we may have to reteach them. Could be a very long term physical therapy, occupational therapy, speech therapy patient going on here. This is not going to be a fast aspect. Therapeutic hypothermia, okay? Very often we do this when there's a brain injury to slow down the rate of the body, increasing healing aspect. You will also see this in the world of cardiac when someone has a cardiac arrest and we get them back. The first thing we do is make the patient hypothermic. This saves the brain. So we do the same thing when there's a TBI. Then we slowly rewarm the patient and we're constantly checking fluid and electrolyte shifting. Then we go to brain death. So there's a lot of different aspects going around with the amount of tests that we do to determine brain death. Now, I know you've all heard the terms fixed and dilated. Pupils fixed and dilated. And while we do look at that, it's not the one and done. But the pupils fixed and dilated is actually something that's referred to as doll's eyes, doll like as in a Barbie doll. And what happens is the eyes stay stationary, abnormal. They are completely dilated, they are fixed, they are unmovable, okay? There is nothing going in with the pupils on this. Along with that, though, there are CT scans done, EEGs done, all those different testing done. So the pupils are just one aspect of all the tests, but it is something that we utilize, especially when it comes to that doll's eyes, doll as in Barbie doll. Something else that we look at when it comes to the end of life is the Jenny Stokes breathing, that agonal breathing that we see with patients. That is a sign of end of life and is coming near. So we want to make sure the patient has the advance directive, a POA, a living will. Are we resuscitating the patient? Are we making them the DNR? A lot of rapid questions do need to be taken. Hospice and palliative care. Sometimes we have time to get hospice involved. Sometimes we don't. Sometimes you become the hospice nurse. And that has happened to me a great deal in the ICU, to the point where the patient is so ill and we don't think the patient's going to make it long term. We will actually keep the patient in the ICU. I was involved in a heartbreaking situation once where we needed the ICU bed for an open heart patient coming out of surgery, and we made the decision to move the patient from the ICU to the med-surg floor, and hospice was involved, and the patient actually died in the elevator with us. And I felt horrible. I cried. Everybody on the team felt horrible because the family could not be at the bedside when the patient passed away, though they were able to see the patient maybe a minute after. It still didn't make anybody feel any better. Any type of cultural and religious practices needs to be addressed. Sometimes it's a very rapid addressing. Sometimes the family comes prepared. Sometimes we're calling different churches. We're calling pastoral care, whatever the family needs. A lot of times you'll see the bereavement cart right out. There might be some drinks, some cookies, some snacks and stuff for the family. I know it's very little, but it's what we can do at the hospital. And then as the nurse, we actually do take care of contacting the funeral home and contacting the state for time of death, because even if the patient had a traumatic brain injury and passed away, or is about to pass away, excuse me, they still could be an organ donor. So we want to make sure that conversation takes place very rapidly, because once the patient goes into cardiac arrest, they're no longer a possibility of being an organ donor. If that's not something you're comfortable with talking to the family about, that's fine. Get a resource nurse, get somebody else, get somebody on the organ donor network to come. They are everywhere. I have friends that live in Kenosha, Racine, Milwaukee that are part of the organ donor network, and they will be sent to hospitals to talk to the families. But once that heart has stopped, they are no longer eligible to be organ donation. So your assessment, your physical, the cooling of the extremities, increased sleeping, their food and water intake will decrease. They will start to become incontinent. Again, they're going to have the Cheyenne strokes respirations. That is a sign of end of life. The patient could be restless, they could be disorientated. The family, anxious, fear, and they're not coping. I've had patient families become violent. Um, they just don't want to say goodbye, especially if this is a very rapid um, event that happened. It can be very traumatic for everybody involved. Desired outcomes that hopefully we met the desires and preferences of the family and the patient. Sometimes it happens really fast, and that's just not something that we're able to do. But if we can make it a peaceful experience, that's our goal. We're going to just make sure that we are suctioning the mouth so aspiration doesn't take place. We'll make sure the patient has O2 on. A lot of times you'll see morphine being given to the patient to help with respirations and different medications to help with the increased production of saliva. Postmortem care, that is the job of the RN and our team. So a UAP, LPN, RN. The death certificate is something that needs to be done by the primary MD. It does not need to happen right away. They can come at a later time and sign that off, but we do need the time of death charted so we can have accurate charting on the death certificate. A physician does not need to be present to call time of death. Two RNs can do it. Um, I've done it without another RN present. I just had the physician on the phone, and it was verified. So there's could be a little bit of um, different policy depending on where you work on that. The determination of the autopsy is for the county specific. If the family requests it, typically if the county says, no, we don't need it, and the family requests it, it is the responsibility of the family to pay for it. I don't make the rules. That's just what happens. You have to look at the hospital policy for that. If there's no autopsy, we remove everything, all the tubes, clean the patient, IV out, everything out. Um, and we put the patient in a body bag and transfer them, or we don't transfer them, but the funeral home comes and gets them. If there's an autopsy, we don't touch the patient. Everything stays put. We can disconnect the IV, we can disconnect the NG, the G tube, but everything stays in the patient, and then the medical examiner will come and get the patient. Um, there are different states that do practice medical euthanasia. That's not something we're going to get into a whole lot. Currently, our state in Wisconsin and our sister states in Minnesota and Illinois don't practice this. It's a huge ethical, legal debate, so I'm sure there'll be more debate to come on it. And the questions for your practice. All right, thanks, guys.